Bueno, muy buenos días. Good
Good
morning,
morning.
everyone. Buen día a todas y todos. Les doy la más cordial bienvenida
I
a este
welcome
evento de la
you
Organización
to this
Panamericana de la
event
Salud con
of
motivo
the
del Día
Pan
Mundial de la
American Health
Tuberculosis este
Organization
año
on the World
2026.
Tuberculosis Day
Queremos informarles que
2026.
tenemos
We would like
traducción
to let you know
simultánea en
that we
tres
have
idiomas,
simultaneous
español, inglés
interpretation in
y
three
portugués,
languages,
y ustedes
Spanish,
pueden elegir
Portuguese, and
el
English,
idioma de su
and you can
preferencia
select
utilizando el
the
icono
language
de
of your
globo que van a
preference
encontrar
using the
en la parte
icon
inferior
of the globe
del
that you will
panel.
have
Mi
on the
nombre es
bottom
Pedro
of the
Abedillo y
screen.
soy el
My
asesor
name is
regional de
Pedro Aberdillo.
tuberculosis en la
I'm
OPS y seré
the
el
regional
moderador del
advisor
evento
on
de hoy.
tuberculosis, and I
Como
be the
ustedes
moderator for
saben,
today. As you
cada año, el
know,
24 de marzo,
each year
conmemoramos
on
el Día
March
Mundial de la
24th, we
Tuberculosis,
commemorate
momento
World
muy
Tuberculosis
importante
Day,
para
a
recordar a todas las
major
personas que
moment
han sido
to
afectadas, están siendo
remember the
afectadas por esta
people that
enfermedad,
have been
y también un
affected
momento
and are
importante
affected
para
by this
reflexionar
disease,
sobre
and an
los avances
important
alcanzados y
moment
sobre todo
to
reforzar el
remind us
compromiso que
of
necesitamos
the
para
strides
poder
and
poner
of
fin
the
a esta
progress and the
enfermedad.
commitments that we
El
need to
lema del
make.
Día Mundial de este año es "Podemos poner fin a la
The
tuberculosis",
theme is
impulsado
We Can
por la
End
atención primaria
TB,
de
driven
salud,
by
la
primary health care,
innovación y
innovation,
comunidades
and committed
comprometidas. Y este lema
communities.
nos marca
And
una
this
dirección
theme
estratégica muy concreta. Todos
highlights
sabemos que la atención
the
primaria de salud
strategic
es lo que puede
direction. We
permitir
know
que
that
la
primary
respuesta a
health
la
care
tuberculosis
allows
llegue
for
realmente a
a
todas las
proper
personas y
response
a
to
las comunidades,
tuberculosis to reach
facilitando
our
esa
people and
detección
communities,
temprana, ese
enabling
acceso
early
al
detection,
diagnóstico y al tratamiento
access to
oportuno y esa
diagnosis, and
continuidad del
timely
tratamiento que
treatment
necesitamos, ¿no?
and
Por
the
supuesto,
treatment
es
that
algo
they
muy
need. Of
importante
course,
para
this
lograr la
is
integración
something
con
very
otros servicios.
important
Eso es
to
clave para la
create
tuberculosis.
integration with
Y es también
other
desde la atención primaria de
services for
salud donde las
tuberculosis and
innovaciones
primary
que
health care
tenemos
and
para la respuesta a la
innovations
tuberculosis
where we
pueden
can find
desplegarse
for
y lograr el
tuberculosis,
mayor impacto
they
posible.
can
Y
be
también sabemos
deployed to
que
have
es
a
donde el
greater
trabajo con las
impact. And we
comunidades
know that
se puede
where this
traducir en
is
una
where the
respuesta
work
mucho más efectiva
lies in
en
the
estos casos. En
communities
otras
to have a
palabras,
more
si
effective and
queremos
sustainable
lograr eliminar la
response.
tuberculosis,
In other words,
necesitamos
if we
sistemas
want
de
to
salud
actually
que
eliminate
sean más
tuberculosis, we need
integrados, más
healthcare
accesibles
systems that are
y
more
centrados
comprehensive, more
en las
accessible,
personas. En el
and
día de hoy, en el
center on
webinario del día de
people.
hoy, vamos a escuchar
Today's
experiencias de
webinar
varios
will
países de la
have the
región
experiences
que
of many
están
countries
avanzando en esta
in the
dirección,
region that are making
integrando la
progress
tuberculosis en la atención primaria de salud,
integrating tuberculosis in
ampliando ese
primary
acceso
health
al
care,
diagnóstico y al tratamiento y
enhancing the access to
acercando los
diagnosis and
servicios a
treatment,
las
and make them
poblaciones
more
y a las
available
comunidades que más
for
lo necesitan.
populations
Nuestra
and communities
agenda
that most
va
need
a
it.
comenzar, va a estar
Our
abierta por un
agenda
mensaje de nuestro
will
director,
be opened by
director de
a
la
message
Organización
of our
Panamericana de la
director,
Salud, el doctor
PAHO's
Jarbas
director,
Barbosa.
Dr. Jarbas
Posteriormente
Barbosa,
vamos a contar
and
con la
then we will
intervención de la
have
doctora
the
Mónica
presentation of
Alonso, que es la
Dr.
jefa de
Monica
unidad de
Alonso,
VIH-Test
the
y
head
virus
of
virales y
HIV,
tuberculosis de la OPS, que nos
STDs, viral
presentará
hepatitis and
los
tuberculosis
principales
unit
avances que hay
from
en
PAHO,
la
who will
región
present the
en la
main
respuesta a la
progress
tuberculosis y las
of the region
prioridades.
and the
Y
response
también
to
vamos a contar
tuberculosis.
con
And
unos
then we will
panelistas de
have
excepción,
panelists,
autoridades de salud, representantes de
authorities
cuatro
from
países
the
de la
healthcare
región
system
que
from
van a
four
compartir
countries of the
sus
region that will
experiencias
share
en la
their
respuesta
experiences
a la
in the
tuberculosis. Y
response to
también vamos a
tuberculosis.
escuchar las
And then
perspectivas
we
muy
will
clave desde
have
el ámbito
the key
parlamentario y desde
perspectives
la
from the
comunidad,
parliamentary
desde la sociedad
perspective
civil. Ya
and
sin más preámbulo,
the community of the
agradecerles de
civil
verdad a
society.
todos y
Without
todas
further ado, I
nuevamente
would
por
like
su
to thank
participación
everyone for your
y su compromiso.
participation
Y
and your
para dar inicio, pues
commitment.
tengo el honor
And to
de
start, I
ceder el
have the
espacio
honor
a nuestro
to
director,
give
el
this
doctor Jarbas Barbosa,
room
quien
to
ha
Dr. Jarvas
grabado unas
Barbosa, who has
palabras de
recorded
apertura para este evento.
an
Adelante,
opening
por favor.
speech for this event.
Estimadas e estimados participantes,
Dear
es un honor
participants,
dirigirme a
it's an
ustedes
honor to
hoy
address
en
you
el Día
today
Mundial de la
on
Tuberculosis
to World
y deseo
Tuberculosis
recordar a
Day.
las personas
I would like
afectadas
to
por esta
remember those
enfermedad y
affected by
reafirmar
this
el
disease
compromiso
and
de la
reaffirm
Organización
the Pan
Panamericana de
American
la
Health
Salud,
Organization's
OPS,
commitment,
de trabajar
PAHO, to
junto a los
working
países
with
para poner
countries to
fin a la
end
TB.
TB.
Lograr esta meta requiere
Making this
liderazgo,
goal a reality
mayor
requires
inversión y la
leadership, increased
participación de toda la
investment, and the
sociedad.
participation of
La OPS
everyone.
estima que por
PAHO
año
estimates that
250.000
in
personas
2024,
contraen
350,000
tuberculosis y
people
30.000
contracted TB and
fallecen en las
30,000
Américas por
died
esta
from the
enfermedad.
disease in the
Sin
Americas.
embargo, hay señales
However, there are
alentadoras.
encouraging
Cada vez
signs.
más personas
More and more
están siendo
people are being
diagnosticadas y
diagnosed
tratadas
and treated in a
oportunamente
timely
y
manner,
tanto la incidencia
and
como
both
la
incidence
mortalidad
and
están
mortality are
estabilizando.
stabilizing.
Esto refleja
This
los
is the
esfuerzos de
result
los
of countries'
países por
efforts to
fortalecer sus
strengthen
respuestas
their national
nacionales y
responses
ampliar el
and
acceso a los
expand
servicios de
access to
salud,
health services,
acercándolos a
bringing them
quienes
closer
más los
to who need them
Vários
most.
países estão
Several
demonstrando que
countries
é
are
possível
demonstrating that it
avançar
is
hacia a
possible to make
eliminação da TB.
progress towards the
Em
elimination
Peru,
of TB.
se han
In
logrado
Peru,
avanços
significant
importantes
progress has
graças a
been made in
inovações como a
reducing incidence and
radiografia de com
mortality,
inteligência
thanks
artificial,
to
que
innovations
supõe
such
a
as
segurança
access to
para o fundo
X-rays with
estratégico de
artificial
laboratório
intelligence and
e as
rapid molecular
plantas
tests
moleculares rápidas integradas no atenção
integrated into the
primária e
primary care
também em
network
diversas privadas
and
de
in
liberdade.
correctional
Paraguai
settings.
ampliava o
Paraguay
examinizar
has
recurrendo à
expanded screening
inteligência
using
artificial
X-ray with
e pruebas
artificial
rápidas em
intelligence and
populações
rapid tests
em
among
situação de
vulnerable populations,
vulnerabilidade,
including
incluindo centros
prisons
penitenciários e comunidades
and
indígenas.
indigenous communities.
Guatemala acertaria
Guatemala
serviços
has brought
mediante
services
brigadas
closer
móveis
to
em
people through
comunidades
mobile
indígenas
teams
e
in indigenous
territórios de difícil
communities
acesso,
and hard-to-reach
mientras que
areas,
em la República
while the
Dominicana ha
Dominican Republic
fortalecido el
has
apoio
strengthened community
comunitário para
support to
melhorar
promote
la
treatment
prevenção.
adherence.
Permitam-me continuar em inglês.
I'll now continue in
Strengthening
English.
primary health care means intensifying active case finding at the community level and expanding access to rapid molecular testing, shortening the time to diagnosis and treatment. It also requires integrating digital technologies and strengthening community-based support to improve treatment adherence, reduce loss to follow-up, and prevent catastrophic costs for patients and their families. The success of these biomedical interventions depends on a supportive environment. Tuberculosis is closely linked to poverty, social exclusion, malnutrition, comorbidities, and stigma. Achieving TB elimination, therefore, requires a multi-sectoral approach that addresses the social determinants driving the disease, including social protection measures. Now is the time to increase investment, accelerate progress, and close the remaining gaps, particularly for populations in situations of vulnerability. We have the knowledge, the tools, and the partnerships needed to change the course of this epidemic. Ending TB is within our reach. With renewed commitment and collective action, we can make TB elimination a reality. Thank you.
Le agradecemos al director, el doctor
So,
Barbosa, por
thank
sus
you,
palabras
Dr. Barbosa,
inspiradoras y
for
por marcar
his
claramente la
inspirational
dirección
words
a seguir.
and
Es
to
un
set
mensaje muy
the
claro
direction to follow.
que
This is a
necesitamos seguir
clear message
avanzando,
that we
cerrar
need to
esas
continue
brechas,
moving forward to
acelerar
close
los
the
esfuerzos
gaps,
hacia la
to
eliminación de la
accelerate the
tuberculosis
efforts
y un
towards
mensaje que
putting an
permita
end to
pasar de los
tuberculosis. And it is a
compromisos
message that
a la acción.
encourages
Nos
that
citaba el doctor Barbosa
going
algunos
from
ejemplos
commitments to
de países
action.
que están
Dr.
avanzando, otros
Barbosa
ejemplos vamos a
quoted
ver
some
a lo
examples
largo
from other
del día de hoy
countries,
también en este
examples that we will
webinar. Muchas
address
gracias al director y
in this webinar.
continuamos
Thank you
con
to the
la agenda.
director,
Tenemos
and we'll continue
el
with the
placer de contar con
agenda.
la doctora Mónica
We have
Alonso, les
Dr.
decía, es la jefa
Monica
de unidad de
Alonso. She's
VIH,
the
SS,
head of
hepatitis
the
virales y
HIV,
tuberculosis en la
STDs,
Oficina
viral
Regional de la OPS.
hepatitis,
Y la
TB
doctora
unit in
Alonso nos va a
Atajo, and
presentar una
Dr.
visión
Alonso will
general
present
de
a
los
general
avances
overview
hacia la
of
eliminación de
the
la
progress
tuberculosis en
towards the
la región
elimination
de
of
las
TB
Américas.
in
Doctora
the
Alonso, por
Americas.
favor, tiene la
Dr.
palabra.
Alonso, you have the floor.
Pedro. Mientras
Thank you,
comparto la
Pedro.
pantalla,
I'll share my screen.
quiero saludar
I would like
a todos
to
los
say
panelistas que nos
hello to all the
acompañan, los
panelists that are
directores del
present here,
departamento,
the directors of
Braulio,
the
también de la
department,
Secretaría de Salud de
Braulio,
Río, la doctora
from the
Alarcón,
Health
experta
Secretariat
de
of
las
Rio,
intervenciones
Dr. Alarcón,
estratégicas de Perú,
from the Strategic
así
Interventions of
como el
Public Health in
viceministro de
Peru,
la Secretaría de
and
Redes de
the
Honduras,
doctor from
también el jefe de programa
Midens from
de Costa
Honduras,
Rica, el doctor Fernando
and the
Córdoba, y
head
todos
of
los
program,
colegas,
Dr. Andres
también
Fernandez
doctores del
Cordova,
Frente
and the
Parlamentario, el doctor
colleagues from the
Gayo, también
Parliamentary
los colegas de
Front,
Asociación
Dr.
Civil y de
Gallo,
Asociación Salud
and
de
from
Perú,
the
además
civil
de todos
society
los
from
participantes.
Peru.
Pedro, que ahora mismo
And
estamos casi
Pedro,
a 600
now
participantes.
we are
Entonces,
almost
bueno,
at 600 participants.
mayor dilación,
So without further
Pedro,
ado,
yo les voy
as Pedro
a
was
estar hablando
saying,
durante
I
los 10
will
minutos
be
de los avances en las
talking
Américas para la
on the
eliminación de la TB.
progress in the
Como
Americans
ustedes
towards the
pueden
elimination of
estar
TB.
viendo aquí, deben
As
ya de
you can see
conocer
here,
cómo
and
en
you
la
might
región
most likely
hemos
know,
sufrido tras el
the
COVID
region
un
after
panorama de
COVID
incidencia
has
aumentada
suffered
de
an
tuberculosis,
increased
si
incidence
bien
of
en el último año
tuberculosis,
hemos
while in the
podido,
last
digamos,
year
desacelerar
we
y
have been
parar y
able to
estancar esa
decelerate
incidencia
and
en un
make
valor
this
de
incidence
350.000
stagnant
personas
at
asesinadas con tuberculosis
350,000
para
people with
2024, así
tuberculosis
como un pico
by
de muertes tras
2024.
el
There was a
COVID.
peak of death
Vemos
after
en el gráfico
COVID.
de la
We
derecha
can
con
see
un
in the graph on
estimado
the
en
right
el
when
último año de
estimated
2024 de
number in the last year of 30,000 people who died because of this disease. So there was a deceleration of the mortality, and hopefully we can see this decrease, this decline in the upcoming estimates. And in the region, we have this outlook of incidence for high burden above 100 for 100,000 inhabitants, 20 countries with a medium incidence and 18 countries with low incidence who are on the path on to the elimination of TB. As regards diagnosis, we can see that on the left, the comparison between the estimate and the reported values with tuberculosis show a gap of around 77,000 people that have not been diagnosed with tuberculosis in the Americas. We know who these people are: people in prisons, people with HIV, people who live in high vulnerability areas. The treatment coverage is 78%. So what happens with this diagnosis gap? As we can see on the right, we have improved a lot, but not enough in the rapid molecular test as the initial test for initial diagnosis. We have made progress 15%, but most cases are not diagnosed with rapid molecular test, which we know that are key because they are highly sensitive and because they can make the diagnosis process faster. So Bacillus coffee is not longer recommended for the initial diagnosis. When we discuss the region and tuberculosis, we should mention the high level of tuberculosis in prisons. What happens in our regions? In our region, as we can see on the small graph on top, this is the region around the world that has had the highest increase of people in prisons. Here we can see as 161% in the last 5 years. Nevertheless, the prisons infrastructure have not increased with the same pace. So most prisons in the region have cluttering. So this is seen in the graph below. As you can see in the region of the Americas with a red circle, we have seen a major increase of TB incidence in prisons. It increased around 90%. And we all know that this is very important, both for the people who live in prisons, the workers, the guards, and the healthcare personnel, but also this high load of people is responsible of 30% of transmission in the community because of this high burden in the context. On the right here, we can see how the load of TB is set at around 28% higher than in the community, reaching 250 times more of TB in prisons. Another important aspects are the comorbidities in TB. We know that alcoholism, diabetes, and malnutrition. And I wanted to highlight the co-infection with HIV. Here we see the cascade of care of co-infection of TB, HIV. I won't delve into details, but I would like to highlight that there is something pending. We have not improved in regards of coverage screening and treatment antiretroviral for co-infected people. And in this graph, you cannot see it, but the PPT coverage in people who live with HIV, people living with HIV, is set at around 28%. So these values are somewhat low, and we need to change this. So what are the priorities towards the end of TB, towards the elimination of TB? There are many things, but we are summarizing here in 5 points. On the one hand, early detection, the active focused search with digital x-rays, with AI, with rapid molecular tests. We will see the tests close to the focal point with people living with HIV, with diabetes, indigenous communities and migrant communities, and other hotspots. We also have timely treatment, shortened and focused, centered on the person with psychosocial support. We should not be remiss of social protection to support these people so that the treatment is successful and provide all the community support for TB treatment besides mental health care for these people. The third priority is preventive treatment, context and risk groups. I said 28% for HIV cases, but we are below 20% in preventive treatment in contacts, considering that we have the shortened schemes of 3 months. The other priority is the integration with primary health care, with comprehensive services that allow for comorbidities to be seen and screening for subgroups like diabetes, alcoholism, and others. And then interventions from people in prisons, which are key, as I mentioned before. As cross-cutting access, we have the multisectorial accountability framework with the involvement of mayors, education, work, not just for the development, and also information systems, data systems that provide support in the monitoring of these interventions. The major participation, involvement of civil society that has its own access, and of course, operational research and R&D in vaccines that hopefully will be available soon. Some examples of the enhancement of digital X-ray with AI. In the region, we went from 9 countries to 15 countries in 2 years that have this equipment, and from 30 to more than 150 equipment in pieces of equipment in Latin America and Caribbean. And here on the right, we see how this active search shows a high value and high performance of people who have TB. We see here the information for 3 countries, but there are many more countries that have had these experiences. And Dr. Alarcón will address this example. As you can see here, out of 30,000 people that were screened, the positive levels were around 2%. Therefore, that primary healthcare access is key. And I would like also to mention the new recommendations that provide us with new opportunities to face TB, like the tests close to the primary healthcare point that are available in the strategic fund. A little bit over $250 per equipment. We can use also tongue swabs, which is the novelty, using these swabs for all the teams, not just for the point of care, but also for the other molecular equipment, as well as the pooling of tests for automatized nucleic acids. As regards treatment, we have some good news and bad news. In the graph, you cannot see the good news, but we hope that in the multi-drug resistant tuberculosis, there has been an increase in the green component, which signals the success of treatment. This is by 2022, stable figures, but now with the oral schemes and shortened schemes for MDR, there has been considerable success in many countries to improve this figure. The bad news is for sensitive TB. On the left, we haven't been able to improve this even after COVID. There has been a slight worsening in this success rate of treatment that should be studied further. And considering all the opportunities with the support focused on people of telemedicine and community support, digital technologies, and the social protection tools, among others. There are several studies that show how PHC show better results in terms of treatment of people with TB. And there is the economic argument for how each dollar invested in PHC can save $16 in expenses, like different non-communicable diseases, anemia, but also TB and malaria. So for tuberculosis response to be more effective and sustainable, the integration and PHC leadership is key. We have an example here of a country of the region that shows the gap. On the right, we can see how only 35% of TB cases are diagnosed in PHC and 65% during a second and a third level of PHC. However, we can see that 34% of the reported TB cases, it took more than 61 days from the symptom to treatment with a 73-day average, and 35% of the deaths happened before starting treatment, and there was 13% of losses in follow-up. PHC strategy can actually help to reverse, to close all these gaps. And to end, I would like to stress that the region is investing. Countries are working hard. And as we can see in the following presentations, they are working for implementing strategic priorities. However, we need to do more. We need to strengthen integration of PHC to provide care centered on people, reduce barriers to access. We know the strategies, we have the technological innovations at hand, and the civil society is committed, and other organizations within the society, governments that are highly committed, for instance, the Parliamentary Front, who are fundamental to change this outlook so that we can actually move towards elimination of TB. Thank you for the opportunity. Thank you,
Muchísimas
Pedro.
gracias a ti, Mónica, por la
Thank you,
excelente
Monica,
presentación. Y creo que hemos visto
for the excellent
con claridad cuál es la
presentation.
situación
We have
en la
clearly
región,
seen
los
then what the
principales desafíos
situation is in the
importantes que
region, the
todavía
main
tenemos, pero
challenges
importantes
that are still
oportunidades y
ahead,
prioridades,
but
¿no? Yo creo que
also with
afortunadamente
important
todavía hay
opportunities and
herramientas,
priorities.
intervenciones que no estamos
Luckily, there are still
utilizando
tools and
completamente y cosas
interventions
nuevas
that
y
are
desafíos
being
que vendrán
underused,
y que de verdad
including
pueden cambiar
new
la realidad.
technologies
Y
that can
sabemos,
actually
vamos a
change
ver ahora, ¿no? Que los
reality.
países están
And we know
avanzando en esta
that
dirección.
countries are moving
Y
towards
bueno,
this
justo vamos a
direction.
tener esa oportunidad de
And we
conocer
will have
algunas
this
experiencias
opportunity
concretas que van a
to
mostrar cómo
get to
es
know some of
posible
these
acelerar la
experiences that will
respuesta,
show how to
avanzar en prevención de
accelerate
la tuberculosis
response
en la
to move towards
atención
integration
primaria
of
de salud y
tuberculosis
obtener
in primary
resultados
health care
de impacto.
and actually
Para comenzar,
reaching
tenemos
impact
el
results.
honor de contar con el doctor
Now we have
Braulio
the honor of
Barreira. El
having
doctor
Dr.
Barreira es
Braulio
director del
Barrera.
Departamento de
He's the
Tuberculosis del
director of the
ITS
TB,
de Especificidades
HIV,
del Ministerio de
STDs, and
Salud
viral hepatitis department of the
de
Ministry of
Brasil.
Health
Doctor
from Brazil.
Braulio,
Dr.
bienvenido.
Draulio,
Le queríamos
welcome.
preguntar
We
desde
would
su
like to
experiencia,
ask you, from your
¿cómo cree que
experience,
puede el primer nivel de
how
atención del
can the
Sistema Único de,
first line
de
primary
Salud, del
health
SUS,
care,
cómo podría impulsar la
how
eliminación
can
de la
we
tuberculosis
encourage
en Brasil?
elimination of tuberculosis in
Adelante,
Brazil?
Braulio.
Thank you.
Gracias, Pedro. Buenos dias a todos. Good morning, bom dia. Vou falar em
Bom dia.
português.
Good morning. I'll
Bom,
speak in English. Well,
já acompanho a luta contra a
as a matter of fact,
tuberculose há
we
algumas
kind of
décadas e
have a few decades
talvez eu soe
on this
pouco
battle.
cético
Perhaps
em relação
that would be a little bit
ao enfrentamento da tuberculose.
subject of
Seja
me
em
to
qual
talk about
nível da
elimination of TB,
saúde que
no matter
nós
what level of our
enfrentemos. Obviamente, eu faço eco ao
health
Dr.
system.
Jabas, a minha
And
colega
of course,
Mônica,
I really
enfim, não tenho nenhuma
echo what
discordância em
Monica
relação
said
à
and
importância
Jarbas
da atenção
said.
primária de saúde como porta de
No shade of a
entrada
doubt, the
coordenadora
importance of
de todo o
integrating TB
cuidado
in
com a
our
tuberculose.
health
Mas
system, and all
considerando
attention must be given
a
to TB.
tuberculose
But
como
considering the
talvez,
fact that
junto
TB,
com a
and
lepra e a
along with
hanseníase, doenças
Hanseníasis
mais antigas
and
que
other
nós temos registro, e saber
known
que a tuberculose
diseases,
continua
according to
sendo,
our
ao
records,
longo de
and
toda a história,
come
exceção dos
to
2 anos em
terms
que a
to know
Covid
that
foi a
TB has
doença que
been
mais matou no
present
mundo, a
for
doença
so long,
infecciosa
and
clássica.
considering that
Mas
COVID
saber que a
was
tuberculose
one of the
sempre foi,
major
nas últimas décadas, e
problems that we've
voltou a
had,
ser
and
a doença que
TB
mais mata, a doença
comes
infecciosa que
back
mais
to
mata
the
no mundo,
scene,
apesar de tantos avanços, né, em
having
todos os campos, no campo
the feud of
diagnóstico,
being the
a Mônica
disease that
falou, Dr.
kills
Jabas
the
falou,
most. And
todos nós
as Monica
sabemos
said,
o
and Dr.
quanto
Jabas
avançamos
said,
na
so
biologia
considering
molecular, nos
all the
testes
progress
moleculares,
that we've had with
na cobertura
um, micro
dos testes
molecular
rápidos moleculares,
biology and the
no
coverage
campo da
with our rapid
profilaxia, que nós
tests. And
temos
for the
também várias
prophylaxis, we
alternativas
have
profiláticas
several
e recentemente,
alternatives.
mais recentemente,
And
a
most
introdução da
recently, uh, uh,
rifampicina em esquemas
Ifapentine
curtos
that
de
was
2 semanas,
introduced in
atualmente de
the
mês, de
12-week
3 HP
systems
e 1 HP.
and the HP, 1
Temos
HP. So
avanços
we still have
terapêuticos, né?
therapeutic
Simplificação de esquemas de tuberculose
progress.
pediátrica, com
And
tratamentos
for
mais
the
encurtados, como
pediatric
cabeça,
patients and the
na tuberculose
4-month treatment.
resistente,
So
com
then we
avanços
also
muito
have the case of
significativos na
resistant
introdução
tuberculosis.
da
We had
breplanida, dos
significant
esquemas BPAL e
advances in
BPAL-M.
our BPAL and
Enfim, temos
BPAL-M
inclusive uma vacina
schemes.
mais do que
As a matter of
centenária,
fact, there is
né,
even
BCG.
the
Então, temos
BCG,
todas as
the vaccine.
ferramentas
As a matter of fact, we
biomédicas
have so
suficientes
many
para
efficient
eliminar a
tools
tuberculose.
to
No
really get
entanto, o
rid
que
of
nós
TB.
vemos é que
Nevertheless, what
ainda
we
temos
see is
problemas de
this
incidência em termos de
plateau in terms
mortalidade,
of incidence and
fruto de todas
mortality.
as
And
inovações
despite of all
tecnológicas,
new
a
technologies we
tuberculose
can
não
count
cede.
on, TB is
E para
still
nós,
there.
a questão da atenção primária da saúde é um ponto pacífico. O SUS se baseia
And for us,
na atenção
in the
primária
primary care,
como
that is a
a
clear
porta de entrada
aspect of this.
e a área
The primary
coordenadora de
care
toda
is
a
the
intervenção em
entry
tuberculose,
point and
mas
contact
infelizmente
organizing
eu serei aqui talvez uma
everything
voz
related to
dissonante no sentido de que
tuberculosis.
não
But
é
I'm
suficiente.
sorry,
É
I need to
absolutamente
be
necessário,
a
mas não é
different
suficiente.
voice here
Nós
and say
temos
that that
feito no
is very
Brasil,
good,
nos
but
últimos
that is
2
not
anos,
enough. In
um
Brazil, in the last
programa
2
muito
years,
ousado, um programa
we
social
have
muito ousado, que é o Programa Brasil Saudável,
created a
e
very
que
bold
a
health
resposta das
program,
doenças determinadas
which is
socialmente,
a program
em que a
called Healthy
tuberculose é a mais
Brazil,
simbólica
in
delas,
which
só se
socially
dará
determined
por
responses,
meio
which also apply
de
to
uma
tuberculosis, can
ação
only
intersetorial. No caso da
be applied
tuberculose, e aí eu entro
in a
na sua pergunta, Pedro,
cross-sectorial manner.
eu
And
acredito que sem
for
uma integração
tuberculosis, I
com
believe that
áreas
without
afins,
integrating
como
with similar
questão da
areas
justiça, e Mônica mostrou
as
como cresce a
does
tuberculose nos
justice. For
presídios, né, de
example, Monica
toda a região. No
showed
Brasil
how
não é
tuberculosis is
diferente.
growing
Então, se não
in
trabalharmos juntos,
penitentiaries in the
do
entire
Ministério da
area. The same
Justiça
applies to
ou dos
Brazil.
seus
And
equivalentes nos
if
diferentes países,
we
no
don't
Brasil nós
work
temos o
together,
Ministério dos Povos
including the
Indígenas.
ministries of
Imagino que na maioria
justice,
dos países
in Brazil, we
ou
also
há
have the
ministério
Ministry of
ou há
Native
uma
Populations,
questão com a
and
saúde
I believe that
indígena.
other countries
Então, é
also
fundamental
have a
trabalharmos
similar
juntos essa
ministry or
população.
something related
E,
to
principalmente,
the health of
com o
native
Ministério
populations,
de
and
Desenvolvimento Social,
mainly
que
working
todos os
with
países
the
têm
Ministry of Social
algum
Development,
ministério semelhante
which is present in almost
a
all the
resposta às
countries,
desigualdades sociais, né? No
responding
Brasil, o
to
Ministério do
social
Desenvolvimento Social e
inequalities. In
Combate à
Brazil,
Fome.
that would be
Então,
the
acho que é
Ministry of
fundamental
Social
essa
Development
articulação que nós
and
aqui pedimos para 14
fighting
ministérios. O Brasil tem máximo
starvation.
ministérios, são 35. E
We
nós
have a lot of
trabalhamos com
ministries in
14
Brazil. We have
ministérios. A maioria
35
deles
ministries, and we
sociais.
work with
Ministério dos Povos
14 of them,
Indígenas, Ministério
many of
da
them
Comunidade
social in
Racial,
character, the
Ministério das
Ministry of
Mulheres,
Native
Ministério
Populations, the Ministry
dos Direitos
of
Humanos,
Women,
do
of
Desenvolvimento
Racial
Social
Equality,
e
Human
tantos
Rights, and
outros
Social Development,
que são
and many
fundamentais
others,
no enfrentamento
which
da
are
tuberculose e
fundamental
na
to fight
tentativa que nós todos
TB
partilhamos de eliminar a
and
tuberculose até
in
2035,
the
segundo
goal to eliminate
metas da
TB by
OMS, e no Brasil
2035,
colocamos uma
which
meta ainda
is
mais
a
ousada
WHO
de
target. In
2030.
Brazil, we have an even bolder target for
Acho, portanto,
2030.
que a atenção primária à saúde ela
I
deve se
believe,
articular
therefore,
com esses
that
outros segmentos que são
primary care
intersetoriais, especialmente
needs
o
to
desenvolvimento
articulate
social,
with the
para
other
que
segments,
a
especially
gente
social
consiga
development, so
vencer os
that
principais
we
desafios
are
que
able to
hoje no
overcome the
Brasil
main
e acredito em boa parte
challenges
da
in
região,
Brazil,
da
and I
América
believe
Latina,
in
se dê
the
na questão do
in
segmento
most
dos
of the
tratamentos, né,
region.
pela
It
característica dos
involves
tratamentos ao longo e que
continuation
dá a falsa
of
sensação de
treatment
cura
because it
muito
is a
rápida,
long
em
treatment that
poucos dias ou
quickly gives the
semanas.
patient
Então, é
a
preciso que as
fake
pessoas com essa
sensation of
tuberculose
cure,
tenham benefícios
so
sociais
that
na
people
transferência de
with
renda e
TB
estímulo à conclusão do
also
tratamento. O
experience
tratamento é
the
muito
social
eficaz,
benefits,
portanto, se a gente
revenue
conseguir
transfer,
garantir
and conclude their
6 meses
treatment
de
because the
tratamento,
treatment is
certamente nós
efficient. If
conseguiremos
we are certain
resultados muito melhores
of
do que a gente tem
going through the
conseguido.
6 months of treatment, we will
Outra
get better results
questão
than one we have already achieved
é a
so far.
fome,
Another matter is
está
hunger,
totalmente
starvation,
associada, né, à questão da
which
tuberculose
is
e
related
do
to
enfrentamento à
TB,
tuberculose. Então, para além
and it
dos
also
benefícios
relates to
sociais ligados à
fighting
adesão ao
TB
tratamento,
beyond
transporte,
social benefits connected with
incentivos
the treatment,
financeiros que a gente possa prover nos pacientes dentro da
transportation,
tuberculose,
financial
a
incentives
eliminação da fome é uma
given to
prioridade
people with
indissociável da eliminação da tuberculose. E, nesse sentido,
is a
novamente,
priority
outros ministérios,
when
Ministério do
fighting
Desenvolvimento Social,
TB.
são
In
fundamentais
this
na
sense,
parceria,
also
no trabalho
other
conjunto entre o
ministries,
Ministério da
including
Saúde
social
e
development,
com a
are
atenção primária à saúde.
fundamental when
Por fim,
working
eu
with
poderia
the
falar muito tempo de muitos
Ministry of Health.
ministérios. Aqui a gente está
I
trabalhando com
could
14. O Ministério
speak
da
about
Saúde lidera
many
mais
ministries. We
13.
are currently working
Mas não
with
posso deixar de
14
falar
ministries
do
headed by the
Ministério
Ministry of
dos
Health.
Direitos
I
Humanos,
also need
todos
to
similares nos
mention
respectivos
the
países,
Ministry of
no
for Human
combate,
Rights or
na
similar
luta
ministries
contra
in the other
o
countries
estigma e o
when
preconceito, né? A
fighting the
tuberculose ainda
stigma
é vista de
and
forma
the
muito. As
prejudice because
pessoas que vivem com
TB
tuberculose são
and
muito
people,
discriminadas em
patients
todos
with
os ambientes,
TB are
inclusive
still
no ambiente de trabalho,
discriminated
o que
against,
leva, né,
especially in the work
ao ciclo
environment,
vicioso em que
which
a
leads
perda de
to a
renda,
vicious
mesmo em lugares, como é o caso do
cycle,
Brasil, em que
so that
todo
loss
cuidado
of
é gratuito,
revenue
desde
in many
teste,
countries, just like
profilaxia,
Brazil,
prevenção,
and it affects
e
all the
tratamento,
testing,
mas a perda
prophylaxis,
de
and
renda
treatment.
é um fato, mesmo
But loss of
nos sistemas
revenue
públicos de
is a
saúde, que é a
factor,
questão da perda da
even
renda.
when
Então, a
it
questão dos direitos
involves
humanos
the
são
public health
fundamentais
systems.
também, entre outras ações, para que a
So,
gente consiga
human rights
sonhar
are
realmente com a
also
eliminação
fundamental
da
among other
tuberculose
actions
no
for
prazo
us
estipulado pela Organização Mundial
to
da Saúde,
be able to dream
pela
about
Organização
eliminating
Pan-Americana de Saúde e
TB
pelo Ministério da
within the
Saúde do
target
Brasil.
date
Então,
determined by the
desculpe assim, um
WHO
pouco
and the Brazilian
excessivo,
Ministry of Health.
mas é uma
I
experiência de
know
mais de algumas
I
décadas em
sound
que
a
a
little
gente vê
skeptic, but
a
it is an
doença
experience of
resistindo a
decades because
todas
we
as
have seen
inovações.
this
Eu me lembro que
disease
no passado, no
resisting
século passado,
innovation. And I
quando eu
remember that
trabalhava
in the
ainda só
past
com a
when
AIDS,
I still worked
a
with
gente falava muito
AIDS,
de
we
dois
used
programas, né, que
we
eram
used to
muito
talk about two
antagônicos, a tuberculose
programs,
e a rafidese.
TB and
infantil e
and
inovação. A tuberculose mudou
Hansen
completamente. No dia
disease.
de hoje tem muitas
And
inovações em todos os
nowadays we have a
campos
lot
do
of
cuidado.
innovation for
E ainda
TB
assim,
in all
as
fields
taxas de
of the
incidência, as taxas
disease
de
care,
mortalidade
and
resistem.
still
Provando
mortality
que
in
não há
incidents,
uma
they
solução
remain
exclusivamente
this
biomédica.
this high,
A
proving
inovação é
that
fundamental,
biomedical
mas a
solution
questão do
alone is
acesso à
not enough.
inovação também é
Innovation is
fundamental
fundamental,
e
but
a
also
articulação
access to the
intersetorial
innovation
para
is
que a gente
fundamental,
consiga
and
enfrentar
also
o problema
connection
que é
between the different
essencialmente
sectors so that we are
social
able
antes de
to
ser um problema
face this
sanitário.
problem,
Então,
which is
seria essa a
social,
minha mensagem
even
nesse dia,
before it
né,
is a
de luta,
biomedical
né? A gente
problem.
realmente continua,
So that
esperamos
is my
poder
message on
comemorar
this very
no
special
futuro
day,
próximo
and we hope
a
we will
eliminação da
be able to
tuberculose, mas
celebrate
nesse
in the very
momento
near
ainda
future
é
the
um
elimination of
dia de
TB.
luta, para
Right
lembrar que a
now, it is
tuberculose
still
existe e resiste,
one day to
apesar de
fight,
todas as
and
inovações
remember that
tecnológicas e
tuberculosis
biomédicas que nós temos
exists
tido.
and resists in
Obrigado pela
spite of all the
oportunidade e
innovations
bom
that
dia a
we have
todas e
seen.
todos.
Thank you very much. And
Doctor Draurio, muchísimas gracias
Thank you
por
very
sus
much,
palabras y
Dr.
por
Drario,
recordarnos si
for
la
your words
tuberculosis
and for
existe,
remember
resiste,
us
persiste.
that
Y bueno,
TB
creo que es un mensaje
resists
muy
and
importante
persists, and
que
this is a
se,
very
todas
important
estas
message
intervenciones,
in spite
innovaciones
of all these
biomédicas
interventions and
que
all the
tenemos no es
biomedic
suficiente,
interventions that
¿no?
we have.
Y
It isn't
justamente ese
still enough.
abordaje multisectorial
So this
y el ejemplo
multisectorial
de Brasil, del
approach and the
programa de Brasil
example of Brazil,
saludable, un ejemplo
the
pionero,
Healthy Brazil, which is a
emblemático para
pioneer,
avanzar justamente
emblematic
en ese
example to
sentido, como
move
mencionaba, con ese
towards in the
involucramiento
sense,
de
as we
14
said, the
ministerios
involvement
que
of
pueden
14
permitir ese
ministries
abordaje de
that
todos los ángulos que
allowed
necesitamos
a
enfrentar
broader
y además de una
approach
manera
from different
integrada, no solo para
aspects in an
tuberculosis, sino
integrated
para
manner, not only
todas
for
esas
TB,
doenças
but
socialmente
for other
determinadas, ¿no?
illnesses
Pues
which
muy
are
importante el
affected
apoyo
by
de
social
protección
determinants.
social.
It's
Mencionaba
important to
también el
have
tema de la
social
lucha contra la
support,
desnutrición y
the
contra el
fight against
hambre y bueno, el
malnutrition
resto de
and
ministerios y de
hunger,
sectores que deben
and
estar
how all
totalmente
other ministries
involucrados
and sectors that
en una
must
respuesta.
be
Quedamos muy
involved
atentos a
in the
todos los
response.
avances de
So
Brasil en
we
este
will be
sentido, que sabemos que van a ser muy inspiradores
looking
para
forward
la
for
región
further
y para el mundo.
advances in
Muchísimas
Brazil,
gracias,
which will
doctor
be very
Claudio.
important for
Y
our
para
region and for all of
profundizar
us.
en esta
Thank you very much
experiencia de
again, Dr.
Brasil,
Braulio. And to keep
me
going into
gustaría dar la
this, going
bienvenida
deeper into
al
this experience
doctor
in
Mario
Brazil, I
Sergio
would like
Ribeiro, que es
to welcome
subsecretario
Mario
de
Sergio
Vigilancia en
Ribeiro, which is
Atención Primaria y Salud
a
en la Secretaría
subsecretary
Estadual de
in
Salud
the
de
state
Río de Janeiro,
secretary
en Brasil. El
um,
doctor Ribeiro va a
in
compartir con
Brazil,
nosotros la
especially in
experiencia del
Rio de
Estado de Río
Janeiro.
de
She's
Janeiro
going to
en la
talk about
integración de la
us about the
tuberculosis
experience
en la
integrating
atención
TB into
primaria
primary health
de
care in the
salud.
state of
Doctor
Rio de
Ribeiro, por
Janeiro.
favor, tiene la palabra.
Dr. Ribeiro, you have the floor.
Doctor, ¿nos escucha?
Sim.
Ahí. Ahora, muy bien, gracias.
Doctor, are you there? Yes.
Bom dia a todos. Bom dia, Pedro.
good
Bom
morning to
dia, Dr.
everyone. Good morning,
Trário.
Pedro,
Fala
Dr.
inicial,
Trario.
dizer que eu alinhado
In
a esse
my
sentimento
initial
do Dr. Draulio, mas
comments,
a
I'd
gente
like to
tem
say
desafios,
that
né? Nós
I'm
temos que dar
aligned
continuidade
with
ao
Dr.
nosso trabalho, dar
Drario's skepticism,
continuidade
but we have the
à
challenge of continuing our
ao
work
nosso
and
desafio.
continuing
Infelizmente, a
uh,
gente tem desafios a
with our
enfrentar, mas
challenges.
temos
Unfortunately,
que
they
colocar os
exist.
pés no chão e ver o que a
We need
gente, né?
to keep
Com toda essa
our
tecnologia, com
head
toda a
clear
disponibilidade dos
and
recursos que a
understand
gente
that with
tem
all
hoje,
the
por que que a gente ainda
technology
continua
and all the
parado no tempo?
resources available
Quero
today, why
agradecer a
are we
oportunidade
still
de permitir
stuck
que o
in
Estado do Rio de
time?
Janeiro
I would like to thank you for the
compartilhe a sua
opportunity
experiência com
for
relação
the state of
à
Rio de Janeiro to
descentralização
share our
da
experience
atenção primária à
in
saúde, nas
decentralizing
ações
in
de enfrentamento à
the
tuberculose.
primary
E
care in actions for TB.
o slide está passando aí para vocês? Tá?
Can you see the slides?
Tá bom. Bom,
Can you
em
see my
primeiro
slides?
lugar, aqui
Well,
a gente
first of all,
mostra basicamente o que já foi comentado aqui.
this
A gente
basically
vê
shows what you heard
segmento
before,
linear em
that
relação aos
we
casos, né? A
see a
incidência, a mortalidade
linear
de tuberculose no Brasil
continuation
e no Rio de
of
Janeiro tem
cases,
enfrentado
incidence, and
esse
mortality
problema.
of
A gente vê
TB
aqui
in
no
Brazil.
primeiro, na
In
aba
Rio, we have the
esquerda,
same problem.
o
On the
Rio de Janeiro em
left,
terceiro lugar na taxa de
we
mortalidade, na incidência de
see
mortalidade
that
por tuberculose,
Rio is
ficando
the
atrás apenas do
third
estado do
place
Amazonas e do
in
estado de Pernambuco.
mortality uh, only behind the states of Amazonas and Pernambuco. So with all this efforts and resources available, the state of Rio de Janeiro has a different city than cities or states that have similar features like the states of São Paulo and Minas Gerais are large metropolises. Well, we face nowadays pretty bad conditions considering the national score on the right. We see incidents. Rio still ranks second in terms of highest incidents in Brazil. At the bottom, we see in Brazil 66% of healing, and in this case reached almost 72%. But treatment interruption is at 15% in Brazil, and in Rio that reaches almost 16.6%. What we need to understand and why TB needs to be treated in a decentralized way in primary healthcare. As Dr. Terrario mentioned, that is the entry point. We have a national pact with the unified health system, and the primary care is nowadays the entry point in healthcare. It is the entry point. They organize and direct care. Dr. Monica said that is an economicity strategy, and that is important to understand. The less a patient needs to move around, the better it is for treatment continuation. So primary care is the challenge, and decentralizing it is the challenge for a state. Brazil has 212 million inhabitants, 5,000 municipalities. The state of Rio has more than 17 million inhabitants. We have less area than other states, but we have 92 municipalities and with a very high populations, with high concentration, especially in the metropolitan area. The capital city of Rio has about 40% of all cases that we have in the city. Our penitentiary system also accrues most of the cases that we need to face, and it's not an easy thing. We have a strategy like the national policy for primary care, which is our entry point, follows the recommendation from the Ministry of Health for TB to decentralize. So we have worked along these lines. About the entry point, we started the regional TB fighting policy. We have a plan after 2021 based on these rudimentary data that we have, and we use very good connection, which is an OPAS connection. We have a technical cooperation number 129, and it has allowed us to invest regionally with the municipalities. And the main axis is decentralizing in primary attention. We identified 24 municipalities concentrating 92% of the cases and are working along these lines of priorities. This shows the spatial distribution in the state. The red dots are penitentiaries. We have 9 cities and 9 units. The blue areas are the 24 municipalities. Lighter blue means because we started with 16 and then advanced to 24 municipalities with 92% of the cases. So we concentrate the efforts of our plan in these 24, but we support all 92 municipalities, of course. These were our actions for primary attention in TB. We first invested in governance because it was very important to work with the municipalities. We work with them qualifying their workforce. We also invested in employing technicians from the central structure to follow these cities. They have vehicles for that and also logistical resources. The acquisition of containers for pulmonary material, for sampling, the use of the TRM molecular biology for easier access to enable quicker diagnosis. And the main item that is a feature of the state is social support through the food support for adherence. And this is valid for all 92 municipalities. It is an innovative action, and Rio has prioritized these actions to avoid abandonment. Nowadays, we believe that very soon we will be able to perceive improvements in these indicators. How do we measure that? And an important strategy was that our team elaborated a set of indicators to measure these indicators. First of all, measuring the coverage in primary care in 92 municipalities, but focusing on those 24. Of course, we created some indicators such as treatment, requests for exams, number of exams, if TDOs were done, contact. So the set of these variables allowed some conclusions. The first one was to improve decentralizing in 14 municipalities, even if some of them reached a minimum of 3.4, and some of them had a maximum of 97.8. And so we see an evolution in decentralizing, which the state has done for municipalities to carry this responsibility to decentralized TB actions. The challenges that we face today are common to the health system, which is turnaround of the health workforce. We have difficulties to maintain and retain these professionals, which impacts continuity of the actions that we have. So these teams are overloaded in primary care, excess workload, small teams, incomplete teams at the municipal level. And remember that in primary care, these actions are carried out by the city, and the state has the role of supporting the municipalities alone, but in empowering nursing forces, it's a very important factor. And that brings us to number 3, which is access to materials. And we also lack professionals, pharmaceutical professionals to make medicine available. Because we have the doctors, but very often dispensing the product requires pharmacists, and the municipality doesn't often have a pharmaceutical specialist, especially when it's farther away. Another item is the diagnosis and integration with the network. Adherence, interruption of treatment is fundamental to intervene, because the strategy being used by the state, as I mentioned before, is innovative. In fact, it is an old strategy to give social support to the population. We also said before that TB is a socially determined disease. 92% of the patients are poor and they require support. And the municipality often has difficulty providing the support. That is why the PAHO and the state took on this role to enable continuation of treatment and follow-up until the treatment is finished. And also the social determinants, we don't need to get into more details of this, because this is a common problem. In Rio, we were able to develop some articulation with the social transportation secretary, so that the patients would get bus passes, say, for example, but now in articulation with the transportation secretary, we were able to reduce the time required for a bus pass to be granted. So they will have support and will be able to go and get their medication. So this activity is done with the transportation secretary and also with the human social development secretary. The next steps, as I said, are renewing the agreement with the secretary. So we recently had a meeting with the health secretaries to make sure that the pact with them from 3 years ago, which was when we started implementing the strengthening plan, so that they could give support to the local teams because they have fragile teams. They often don't have a doctor. The teams, but now the teams only be responsible for the TB program, and that really endangers care to the patient in the city. So this agreement will be renewed the next meeting in the next 2 weeks, and we will strengthen with municipalities, especially those 24 priority ones, to avoid lack of continuity in these actions. Also, strengthening qualification primary care and strengthening the primary attention are the next steps that need to be invested in. That is what I had for you. Some aspects we would like to clear up. We also have remote training for handling and surveilling TB, also building evaluation methodologies to implement quality seals, acknowledging the evolution of the quality in the city for these professionals is a very important step for them. And also because PAHO can help in these advances, but we also need to acknowledge their efforts. And sometimes the production of it. And also, if you see and use this QR code, you will see 12 videos that were produced for the units explaining basic things. What is the fundamental role of the community agent in the TB plan? So how to learn about cases and direct them to the health units. So how to follow up these contacts and break up transmission and contagion inside families. These are advances we were able to make. Today, sorry, I'm racing here because I only had 10 minutes. I'm at 14 minutes now, but that's what I had for you. Thank you very much for the opportunity. We apologize. The secretary couldn't come, so she asked me to conduct this presentation. Thank you very much for your attention.
Muchísimas gracias, Dr. Mario, por la excelente
Thank you very
presentación.
much, Dr. Mario, for your great presentation. I especially say hello to Dr. Claudia Melo, the Secretary of Health, and of course, congratulations to your state for this great investment to response to TB and your integral approach and the focus in the PHC in a systematic way so that you can measure the advancement of this progress in TB. Of course, it's very important the investments that you are doing to support food programs, and we will be looking forward to hear from you in terms of innovation in methodology and assessment of quality. That may be a very positive advancement. We know that it hasn't been easy for you, but I, together with the team, we had the opportunity to talk with the state team and see the amazing job that they are doing. I think this is a clear example on how a sustained program through innovation is translating into impact. So congratulations and thank you very much, Dr. Melo, Dr. Ribeiro, Dr. Braulio. So moving on with our schedule, we are more than 800 people connected, and I would like to welcome now Dr. Valentina Alacton, which is the Executive Director of the General Director of Strategic Public Health Intervention of the Ministry of Health of Peru, who will be sharing Peru experience in the innovation in the first level of care in Peru. So, Dr. Alarcón, it's a pleasure to have you here. Thank you very much for your participation. You have the floor. Thank you very much, Dr. Pedro. Thank you to all the teams that are here with us today. And I will briefly present you the advancement that we had in Peru in terms of innovations in our country. This is Peru's situation. We had a geo-reference in the different districts, in the hottest, as we call them, districts. More than 34 cases of TB. We have more than 2,000 cases of MDR and disease, 11.8 with diabetes, 1.4% with migrants, 1.8 with indigenous. I told you about the healing rate with MDR and TB. And with the healing rate, we are above 85% that I will tell you about later. So our problem is focalized. We know that we need to prioritize the spots, and the actions to be implemented is to organize PHC. We have been working with the purchase of equipment for molecular biology in the past years, and we have implementing and expanding this at a national level. First at the regional level, national level, and then PHC. As you see in the map, we began with 16 pieces of equipment at the DIRIS level. Then we broadened this to 29 pieces of equipment with molecular biology. Here you see the different colors, and we also introduced 33 pieces of equipment of TreadNet, basically in Lima and in priority places, in order to have to get closer to the population to detect TB and their resistance. But also we implemented ACG to measure equipment also for EKG and AHC through different test and treatment schemes. This is the evolution about the gene expert through the years. We started in 2023, then 2024 with 81 pieces of equipment, and by 2025 we finished with 104 pieces of equipment and 33 TreadNet. This is coordinated strongly with my HIV colleague. We had a progression and an increase to molecular tests with the reference tests with 10 color tests. Those hospitals that have and keep working with this work, and we also with diagnosis. One new initiative that we have so far is to be able to introduce the close point of care, especially for rainforest area, in which we have identified at a district level those who have at more risk. Here we have Loreto and Amazonas, which are very difficult to access, same as Madre de Dios and San Martin. This is more or less the strategy that we planned with the technical teams. These are packages to which healthcare centers they are addressed or allocated for the TB cases with this new technique of close point of care in POC.
but in this case are thus at sub-levels in this healthcare level, which are difficult of access, but we have 25 teams that will be distributed through 6 regions with 32,000 tests.
This is the packaging and how they are organized. And depending on the quantity and the number of cases on these points, these hotspots, we will have the different scenarios. In the picture that you can see on the right, we can see the mini dock, which is a thermal recycler. And depending on the kits, in this case, in package 2, we have 1,500 tests. These mini docks are portable, are easy to process. It is reloadable. The battery lasts between 8 to 12 hours, and it can work at 40 degrees Celsius. So that what we are seeking for is to find TB cases in a timely manner because of the geographical access that we have, because we do have problems with co-infection in remote areas, especially in indigenous populations. The active search strategy is being implemented at the national level. There are 22 health territories in Peru, and this strategy is to make X-rays available with AI plus molecular tests across the country. As you can see here in green, the regions in green are the ones that have the X-ray equipment with AI. We are only missing 7. We prioritize the regions with the highest burden, and we are working with Gene Expert to make the access available to primary health care. These are some of the results we can see in this box in red in the active search strategy since 2022. 246,000 people have been screened. 244,000 have been screened with X-rays. And out of this total, 26,483 have come out positive. That accounts for 10.8% of the screened. Suspected cases, 43,397. Why? Because it is mandatory for our doctors to screen with a molecular test. And there were 37,234 bacteriological tests, and we have found 3,711 cases. This is the population that has been intervened so far. We have segmented this in prisons, healthcare centers. In the last quarter, when we saw the equipments for X-ray, plus the TrueNats in Callao and some other regions, and the results that you see here, it's in the prisons, almost 2,000 cases found. In healthcare centers, 609 cases, and the AI cure methodology, 679 cases. And in some other campaigns, there were 252 cases. So this is part of the 3,711 cases of the active searches that we conducted, and within the healthcare centers is where we need to strengthen the active search. This is the implementation of molecular biology. Look how we have enhanced the number of molecular tests compared to other years. In 2022, we had 39,000 tests. In 2023, 47,000. In 2024, 71,900. And 2025 with 198,000 molecular tests for identifying cases. And so far, almost 41,000 tests. This enhancement of equipment has enabled prioritization and access to population to have a timely diagnosis. As regards the shortened oral schemes, we have 3,442 patients that receive shortened oral schemes. We have the comparison on the right that were compared with the injectable schemes of the first semester of 2000, which were the highest numbers. Now we stand at almost 35.8 and 8%, 85% of abandonment rate. And the implementation of TB preventive therapy, we are strengthening the examined contacts, and we are finding further cases because this is being used for tests that some other tests that are not sputum. And for 2025, we closed this with 61.4% of the total of children under 5. For the SIG-TB scheme, there's a new version because everything needs to be gathered with official data from the Ministry of Health. We have worked to introduce cases and preventive therapies for TB, and also visualizing of the test through NEP-Lab, which is the official system for the National Institute of Health. And there is articulated work with the civil society and primary health care. We are strengthening the active search of cases with like intramural and hotspots, and for pediatric TB, and the therapies to be complied with. And of course, diagnosis and treatment for multi-drug resistance TB, and also social programs. Dr. Braudio talked about social determinants of health, and through social programs in the country, we are admitting countries not because of their TB status, but because of their social economic condition. This is what I wanted to share with you. Yesterday, we celebrated the World Tuberculosis Day. This is a human lung, as you can see here, that was celebrated together with our authorities. Thank you very much.
Excelente, doctor Alarcón. Muchísimas gracias
Thank you,
por
Dr.
la
Alarcón.
presentación y
Thank you for
felicitaciones
your
también al Perú
presentation, and
por esa determinación
congratulations,
de
Peru,
avanzar
for
de
your
forma
determination
acelerada y de
in
forma muy
advancing,
ambiciosa
in
la implementación y la
accelerating
expansión de
with
estas
ambition
innovaciones
the
que tenemos
expansion of
disponibles
these
y
innovations that are
enfocados en
available,
poblaciones de
and
riesgo, como
focused
comentaba,
on
en prisiones, pero con ese
risk
enfoque también de
population in
fortalecer
prisons, for
el
instance,
primer
but
nivel
also with the
de
focus of
atención, ¿no? Hemos
strengthening
visto que
primary health
esta
care.
apuesta estratégica
We have seen that
de
this
Perú ya está dando
strategy
resultados
of
concretos con
Peru
avances
is
en la reducción
rendering
de la
results
incidencia
in the
y
advancement
de la
of
mortalidad, ¿no?
the
Y
reduction of
también muchas
incidence and
gracias,
mortality.
doctora, por presentarnos más
And
información
thank
sobre
you,
estas nuevas
doctor, for
tecnologías,
providing
el mini
further
blog, las nuevas
information
máquinas que
about
tenemos de
new
pruebas
technologies,
moleculares que
the mini
pueden
blog
permitir
and the
hacer el
molecular
diagnóstico del ATB
tests
más
that
cercano
enable
al paciente
detection of
en zonas de
TB
difícil
to
acceso y
make it
Perú, por ser
closer and
de
more
los países
available to
pioneros en
patients.
introducir en
Peru is
introducirlo.
one of the
Recordarlos
pioneer
pues es que
countries in
está
introducing
disponible también
this.
a través del Fondo
And there are some
Estratégico
other countries which
de la
this
OTE. Es una
is
experiencia muy
available through the
valiosa,
strategic fund of
sabemos que muy
PAHO.
inspiradora para otros países de la
This is
región y
quite
certificable.
inspiring for
Muchísimas
other
gracias,
countries of the
doctora
region. So
Alarcón.
thank you, Dr.
Muy bien,
Alarcón.
mira,
Thank you,
gracias.
Dr. Averillo.
Continuamos y nos
So
trasladamos ahora
now
a
we are
Centroamérica.
moving to
Vamos a
Central
Honduras y me gustaría
America.
dar la
We go
bienvenida
to
al doctor
Honduras, and I would
Ángel
like to
Eduardo
welcome
Midense
Dr.
Ochoa,
Angel Eduardo
subsecretario de
Midense
Redes
Ochoa,
Integradas de Servicios de Salud de la
Undersecretary of
Secretaría de
Integrated
Salud
Networks of Health
de Honduras. El
Services
doctor Midense va
of
a
the
compartir
Secretariat of
con
Health of
nosotros la experiencia que tiene
Honduras.
Honduras
He
en
will
la
share the
integración de la
experience
tuberculosis
of
en la
Honduras in
atención
the
primaria de salud
integration
y el
of TB
impacto
in
que
primary
están
health
teniendo en
care
concreto en
and
los
the
resultados
impact
de
in
tratamiento. Doctor
the
Midense, muchas
treatment
gracias
results. Dr.
por
Midense,
acompañarnos y le
thank
paso
you
la
very
palabra.
much for joining us. You have the floor.
Bien, buenos días. Buenos días a
Good
todos.
morning. Good morning, everyone.
En representación del doctor Ángel Eduardo Mides,
On behalf
secretario de Redes
of the Secretariat of the Integrated Networks here in Honduras. We are happy to be sharing this.
Disculpen,
Doctor, I'm sorry. In the approach and the control and elimination of tuberculosis. We will discuss the experience and the strategies that we have set here in Honduras. Within the framework of the National Plan of El Salvador, Doctor, I apologize that I interrupt, but there's some echo. Maybe you have another microphone open, please.
Podemos compartir su presentación porque la
So
tenemos disponible.
we can share your presentation because we have that available. The model based in primary health care. We have the strategy for family and community health care. This is a strategy that is focused to improving access and coverage of services, especially in most vulnerable populations, family, healthcare professionals, a general practitioner, and a healthcare promoter with a focus in promoting and preventing health. First of all, that is the core team, but under that core team, we can add some other healthcare professionals according to the need that may come up when we have some special attention or special care or healthcare problem. The family healthcare strategy promoted by the Secretariat of Health is focused on primary health care to improve the access, quality, and coverage of healthcare services. Family healthcare teams are focused on primary health core and improved by 80% promotion and prevention of health. And the key strategies and components that are set in the family healthcare strategy is making each territory and sectors for diagnosis of the geographical area and specific populations in each family healthcare team. They create the sectors, the territories, and they create a family record where the determinants of health are set, risks are set of the person, the family, and the community. And then we define this in order, and then we have interventions in the community oriented to family and the person. In this case, as regards tuberculosis, the family healthcare teams play a major role because they have mapped risk families and they detect early TB through the monitoring of respiratory symptoms. That team of family health know each person and the families, and the early detection and the timely diagnosis and the shortened and supervised treatment has been a success because if they detect that that person is not following treatment, they identify that, and moreover, the community involvement with the teams. There is continuous involvement of community leaders identifying all these needs in health. The same goes for the teams in times of emergency. They are fundamental to provide responses. And we, of course, look for improvement in access and healthcare through the different teams.
Entonces, damos paso a la presentación que tenemos como Honduras en los logros.
So now we are going to share about the progress in Honduras with TB. Good morning, everyone. As regards the integration of TB in primary healthcare and its impact in the results in treatment in Honduras, Honduras made great advancement of results, but of course we need to keep working. My colleague has already talked about the priority lines of our governments of our country, which is PHC. Of course, our country is composed by 20 healthcare regions that match the departments and the largest metropolitan centers. And we have made progress in the incidence rate of TB. We've seen reduction, the use of molecular equipment, the patient care, and at a country level, we identified that TB is basically concentrated in 10 regions, in 48 municipalities, in the 290 that the country has, and in these 10 regions, 70% of TB is concentrated. We made an important leap in terms of diagnosis. In 2016, we only had the regular test, and in 2024, we have 21 expert equipment. This equipment covers 17 of the healthcare regions out of the 20 that we have in our country. This year, we will keep moving forwards because we will cover all the regions with this new technology, and we will make another leap to establish a pilot program in 10 municipalities. In those, we have highest incidence rate to expedite the sampling, and in these storage facilities will cover the basic needs such as the cold chain and all the equipment needed to receive samples and then to transport them within the first few hours to the regional labs where this new equipment is installed. Our country also made great progress. We updated our national algorithm in terms of diagnosis. We have updated our national strategic plan for TB 2025-2030. We have updated our regulatory documents, especially in terms of treatment and diagnosis, where we added the shortened treatments, and for second lines, the shortened treatments as well. This was great progress, and this regulation also include the prevention and care for TB. We included topics such as psychosocial support for TB patients and the approach to this disease for aftercare. We have strengthened the molecular diagnostic network. We have all the new equipment needed for diagnostic purpose for RRR, MDR, TB.
Como mencionamos, pues
As I
ya
mentioned before,
avanzado mucho en que los
we have
equipos,
made
incorporar
progress
equipos donde las pruebas
with the
moleculares,
addition of equipment
incluyendo
for molecular tests, including the
y
expert
mencionamos,
MTB
de los
XDR.
21 equipos que tenemos
And
ya
out of the
actualmente en el país,
21
11
piece
ya
of
se
equipment that
encuentran
we have,
en
11
proceso de
are
conversión a
already in
plataformas
process
híbridas.
of conversion to
Algo
hybrid
importante es
platform.
que
And
tenemos el
one more
aseguramiento de
very
la adquisición
important thing
sostenida de
is
medicamentos de
that we
primera y
have
segunda línea,
the
con fondos
assurance
nacionales,
for
pero con el
sustained
apoyo del Fondo
acquisition
Estratégico de
of
Medicamentos
second line
de la
medicines
OPS.
with the
Actualmente el
support of the
país
government
está
and
también en un
PAHO.
proceso de
Currently, our
suscripción de
country is
compromiso
also
para la
in the
adquisición de
process to
medicamentos
establish a
y esto
trust
pues va a
for the
acelerar
acquisition
y
of
generar una respuesta más rápida
drugs to
de que los
generate
medicamentos se
a
distribuyan a
more
las
timely
regiones
and
1 donde se
duly
reportan los casos
response
de tuberculosis y
as
se
drugs
asegura
are
de que ellos pues inicien el tratamiento
distributed
lo más pronto
into the
posible.
different regions to start treatments as soon as
La
possible.
siguiente. Ok, algo importante, ya por
Another
mencionar
very
algunos logros,
important
es
thing
que
to
Honduras ha
include
superado
within our
las metas
achievements is that
programadas en cuanto a la
Honduras
notificación
has
de casos. En
exceeded
cuanto a los
the
casos
expectations in
programados,
terms of
actualmente
notification of
registramos un
cases.
crecimiento de 1.87%.
We
Y
increased
lo más importante es que el
almost
72% de los casos
102%
diagnosticados se está haciendo
our
con pruebas
expectation,
moleculares.
and
Estamos dando un salto importante y
72%
ahora
of the cases are
la
being
vaciloscopía
diagnosed
ya
through
es un
molecular
método para
tests.
control y seguimiento,
We know that
pero
this,
ya las pruebas
we
moleculares
also
son la
have
prueba
a
de
follow-up
elección para el diagnóstico
procedures,
de
but
tuberculosis, la primera prueba de
nowadays
selección.
molecular
La
tests are
mortalidad, pues
the most
afortunadamente, como
common
vemos
way of
en la
testing.
gráfica, ha tenido una
Mortality
disminución
by
sostenida
TB had a
en los
sustained
últimos
decrease in
4
the
años
last
y
4 years,
actualmente pues nuestra
and
tasa de mortalidad fue de
currently
1.15 por
the
100.000 habitantes.
death rate
En cuanto
is
a los pacientes
1.15 per
con
100,000
diagnóstico de
inhabitants.
resistencia a RR
In
y
terms
RR,
of
tenemos
resistance
algo
to
importante que el
RRMDR,
92.67%
this
iniciaron
we
sus
have
tratamientos
almost
acortados de segunda
92% of the
línea
patients began
y
with a shortened
algo
treatment
importante es que
for
hemos
second line treatment,
mostrado una mejoría en la tasa de éxito de
and we
tratamiento
had an
en
improvement
personas con RR y
in
LR
the
del
success rate for
57.4 en el
treatment
2022
for
a 67% en
TB-RR
el
or
2025. Entonces,
DR
esto es un logro. En
from
el
67%
2025, esto es un dato importante,
in
considerando
2022
pues
to
que los
67%
pacientes
in
con
2025.
MDR, RR
So
son
this
pacientes
means
que ya
that
llegan en una fase
MDR
bastante
patients
complicada de su
that arrive
complicación
are
y
already in a
principalmente son
very
captados
complicated stage of the disease,
en el
and they
segundo nivel
are
de atención. La siguiente.
integrated into the second care attention level.
Hemos tenido una tasa de éxito de tratamiento
We had a
sostenida
success
mayor del
rate
80% en los últimos 5 años.
sustain of more than
En los
80%
últimos
in the
4
last
años fue todavía
in the last
actualmente,
4 years,
pues en el año
sorry,
2025 está pues
and
del
in
83%.
2025 this was of
Mencionábamos la distribución de los equipos a nivel
83%.
de las
We
regiones. La
mentioned the
doctora
distribution at a regional level.
mencionaba muy bien el
My
tema de
colleague
los equipos de
also
salud familiar,
mentioned
que es
the
prácticamente
equipment
la
of
punta de lanza del modelo nacional de salud,
family healthcare,
donde estos
which is
equipos de salud
our
familiar están básicamente en
main
los establecimientos de salud,
entry
conformados por un
point,
equipo de
which are
médicos,
within the
promotores de
healthcare
salud, enfermeras, son los que
facilities
hacen el
made up
levantamiento
of
socioeconómico en esa comunidad
nurses
y
and doctors,
el
which
tema
do the
de las
first survey
morbilidades
of
existentes en ese núcleo familiar y
inhabitants
también de la
and the
tuberculosis y de las acciones
comorbidity in
de promoción
patients,
y de prevención y sobre todo del aseguramiento del
and that
diagnóstico de y el
also
seguimiento del
lead
tratamiento.
with
La
a
red de
program
colaboradores voluntarios
for
está incluida en estos
prevention
equipos
and
de salud familiar
diagnosis.
y son los
We
que
have our
apoyan mucho en
teams
la
of family
captación
healthcare
y en el
that
aseguramiento
also
del tratamiento
support
directamente
in
observado a las
the
poblaciones
assurance
a las
of the
poblaciones con
continuity of the
tuberculosis.
treatment.
Contamos con una sociedad civil
We have
organizada
an
conformada en la
organized civil
Asociación Hondureña
society
contra la Tuberculosis
in
y
the
también una mesa
Honduras
intersectorial donde
TB
participa la
Society, and also an
academia, sector privado,
intersectorial
otros organismos
roundtable
como la
with
Corporación
different type
Internacional
of stakeholders,
y otras
local and
instituciones
national
voluntarias
and
y este
internationals.
caso pues
in order to make progress or an organized work to discuss together with the government, because TB has caused unemployment or lack of education. This also involves the transport of patients, because there are some areas in Honduras in which the transport is also through airways. So this is very important for the treatment of patients. We have insurance drugs for first and second lines acquired with the strategic fund of PAHO together with the national government to guarantee the continuance of treatment. The National Strategic Plan has 4 milestones: early diagnostic, active search, the adherence of treatment, specifically in population at risk, which is population with comorbidities and prison population, and also the implementation of preventive treatment, which used to be only for patients with HIV and for close contacts and population under 5 years old. But nowadays, the preventive treatment it's also extended, and we expect to have a more important coverage in all the country. From PHC, we are making a lot of efforts. This is being extended to molecular diagnosis to all regions. We are already implementing for all positive cases, making different tests to look for another drug resistance. For those 10 municipalities with the highest burden of cases, and together with the prison ministry, we have an intervention plan within prisons where we have the highest rate of incidence, in order to get 100% of the cases. This is a 2-year plan that includes the incorporation of new technologies. Another important topic is the strengthening of the IT system that needs to be updated, adding new variables for monitoring and treatment purposes. Within this intervention in prisons, and coordinated with the National Prison Institute, we are in the process of acquiring 4 portable X-ray equipment with AI assistance that will be implemented in prisons firstly, but we have a goal that even if we start with 4 equipments, the idea is for 2030 to have at least 1 piece of equipment, 1 X-ray equipment at each prison. This means not only to address this within prisons, but also to have this available at each PHC center. We continue with the training for all healthcare professionals and volunteers in terms of the new regulations. We keep updating the networks of volunteers for PHC and family support, and we keep the follow-up and monitoring plans. So as my colleague, Dr. Costurbina mentioned, which is the coordinator of the first level, The PHC teams are basically oriented to early detection, to active search, monitoring and implementation of the shortened treatments. One of the milestones of the government is to strengthen PHC, and in this sense, we implement actions to reduce mortality and to close the existent gaps. We will keep investing in the PHC teams in order to make progress towards our goal to eliminate TB as a public health problem in Honduras, and this is our direction. We know that many of us will be able to broaden this information because this week we will have the visit of the PAHO experts in our country, and I think this will be very enlightening for the new experience eye guidelines, which will be really useful for our country as we are beginning a new government, and will be really beneficial to complement our programs. Thank you very much.
Muchísimas gracias, doctora Urbina, doctor Orlinder. Un gusto verle. Muchísimas gracias.
Thank you very much, Dr. Urbina, Dr. Mirense. Thank you for your presentation, which has shown how strengthening network services can improve the opportunity for diagnosis and support to treatment. Your work is quite relevant, the work you do with the communities. The integration of call balls of malaria, integrating them in the work with tuberculosis in order to screen the available resources to enhance the reach of interventions. Thank you, doctors, for your presentation and your experience. So now we'll go with another country. Dr. Andres Fernandez Cordova from the TB program of the Social Security of Costa Rica, who will be sharing the role of PHC in the plan of TB elimination in Costa Rica as a low incidence country. Dr. Fernandez, you have the floor. Thank you, doctor. It's a pleasure to share this with you. And as Dr. Pedro was saying, I will share the role of primary health care from the institution in Costa Rica towards the elimination of tuberculosis. It is always to have a good starting point, reviewing the current status of TB in Costa Rica. As you can see, we have recent data. We see here TB behavior in 2025 with the main indicators. The total amount is 510 cases. After 10 years, we exceeded the threshold of 500 cases, which were actually quite below in 2024 and 2023. We have surpassed this number in absolute cases by 510. The incidence is 9.78 per 100,000 inhabitants. As the doctor was saying initially, makes Costa Rica belong to the group of countries, 18 countries that are in the low rate. If we keep this trend, because of the highest cases are present in males, doubling the ones for females. On the right, we can see how the incidence behaves in absolute cases of TB in Costa Rica according to the geographical administrative division from the Social Security office in Costa Rica. As we see, there are some regions in the south and in the center that have absolute number of cases that are higher than others. In specific regions, for instance, the one that is on the seashore. This is a bordering region with some specific conditions. In the last couple of years, these regions have higher incidence. And as we can see here in the graph, exceeding the national average. And other regions that are on the Pacific and that are also on the border, they are risk cases. In this graph, we can see here that we have presented before, we can see how in this year we were able to close the gap in the expected incidence for this year. It was 9.78 for 510 cases as an absolute number. This is what we were able to accomplish. The behavior since 2015 has placed us underneath the expected incidence, and by 2025, we were able to match this, reducing the incidence between the expected cases and the reported cases. This is the space distribution in the country. Costa Rica is a small country, but we can see here how the distribution of cases is upheld across the country. There is no specific place where there are no cases. The highest concentration, because of the shade of blue, is in the central area, specifically in the capital city and the surrounding provinces, the metropolitan area. However, we see an increase in the shade of blue in some cases that are grouped towards the Caribbean and towards the Pacific Ocean, specifically in the north and in the south. So here we can see that despite only having 510 cases that are distributed across the country. And this shows the main risk conditions that we find in the cases reported for 2025. Most cases have a risk condition or a risk population of migrants. As we can see here, we can see a person that may have two or more risk conditions. So here this graph shows in the second place people living with HIV, people in prison, smokers, people who live on the street, indigenous communities as the main risk groups for the reported cases. We cannot overlook renal transplant and people who are former smokers and healthcare staff. Okay, so what is the role of primary health care in the elimination of TB in Costa Rica? To that end, we need to discuss the integration of primary health care as regards TB. There are strengths, especially what enable us to have a national standard as to how we're going to handle TB from the first line care. Of course, the legal foundation in Costa Rica, because of the laws that we have to address tuberculosis, which enable us at both at the public and private level to set some parameters on the care, diagnosis, and detection of cases that must be implemented across the country in all the healthcare services. Here we can find some other regulations like the National Law of Health and some other standards that are used at the institutional level. Likewise, we have an intersectorial network led by the Ministry of Health that enables the approach of TB cases. Here, as the spearhead, we have the Ministry of Health that shares the responsibility with the Social Security Office of Costa Rica, with the Justice Ministry, with the National Lab Organization, and the Ministry of Agriculture that are involved in the approach of tuberculosis. And at the local level, we have teams across the entire service network, which will facilitate detection, diagnosis, treatment, and follow-up of cases. People who are properly trained and continue to be trained across all levels of care to address TB. This is an important image because from the primary healthcare perspective, in Costa Rica, we are going to address the first line of care. This is the distribution of the organizational chart of the Social Security Office as regards the services. On the right, we see the hospitals that belong to the third level of care: general, specialized, and regional hospitals. All of these are the first line of care. There are 105 healthcare areas and a first line care that is made up of 529 facilities of EBIs. I'll let you know what EBIs are, and 647 periodic visit facilities. Now we will focus as to how tuberculosis is addressed specifically at the most basic level, represented by the EBIS facilities. So, a basic team of comprehensive care in health is called EBIS, by its acronym in Spanish. Created in 1995 after the healthcare reform, where the first line healthcare services went from the Ministry of Health to the Social Security Office, made up of a nurse, a primary care assistant, and some other specialties if it is required. For instance, nutrition, social work, physical trainers, and also a pharmacy technician and a laboratory technician for diagnosis and treatment. These primary healthcare centers provide curative and preventive services at an average of 4,584 people across the country. The average, right? Why are these centers important? Because they are in charge of detecting and diagnosing tuberculosis, and also the follow-up and treatment of the users once they are diagnosed. As regards detection, they are in charge of conducting activities to actually reach those cases. Diagnosis, as you can see here in the second line, is concentrated in these centers, in this first line of care, which provides a percentage of 75% of diagnosed cases, which means that the cases reported of tuberculosis happen in the first level of attention of care. Some others are related to other comorbidities, and for some other reasons may produce a tuberculosis diagnosis. This diagnosis stems from active search and passive search involving all the staff of the country. As I said before, medical staff, technicians, and nurses. And they work according to the calculation of the detection goals that at the national level is provided using the Screen TB tool based on specific population risks, risk populations, in these units. For passive search activities, they are conducted in the centers through the consultation of the general doctor, of the general practitioner, and in the home visit. As Honduras was saying, they have something similar, and here what they do, they can visit almost 100% of the reported cases. During these visits, where health is reaching communities, where colleagues are going to the homes, and part of the work they do include the detection of potential TB cases or suspected tuberculosis, and they are in charge of organizing active search activities. This is also done institutionally. But from the Social Security Office, there is also local ministries. There are strategies of active search in specific populations that are priorities every 5 years, with a specific scheduling every 5 years.
Here we have priority population. As I told you, there are 134 units which are priorities. We have 82 governing areas from the Ministry of Health with their own strategy, and 32 institutional attention centers within prisons which perform these active searches that will be performed within this 5-year period. Likewise, in order to prioritize this population, we need to see the full number of cases, the percentage of detection, as we call the screen TB. Using this tool, we take specific populations at risk in these municipalities. We also consider affiliated population, assured population, migrant population, indigenous population, prison population, geographic access, and private healthcare. As regard treatments, people in the first level of attention, PHC, they have a very high success rate. And in the last few years, we were above 90% of the treatment. And this is specifically because this is strictly monitored. In Costa Rica, all treatments are delivered in person, and all people with TB need to follow this rule without any exception to change treatment. This is specifically localized in PHC. So this means that EBIs are the only specific centers to treat TB patients. Even the primary healthcare assistants go daily in person, and they monitor personally, not only with TB patients, but also with identified close contacts that need chemoprophylaxis. So we see how this primary care is concentrated within these teams, and how this figure of the ATAP, the primary team, allows us to have a strict monitoring for patients and contacts. As regards contact investigation, this is a process which is allocated to the epidemiological surveillance local commissions, which are in charge of doing this epidemiological investigation to search for contacts and to study if they need preventive treatments. This is done by means of visits to the family, to the workplace, or social areas. In case of positive cases, this personnel go to these different places and they identified contacts and also see if there is another possible case to address it. 100% of contacts are identified as studied in case of a positive cases, and we have a small statistic here from 2024. We had from the 400, more than 400 cases, we had almost 107,000 contacts. Here we have an example of success case in case of risk population. We use this photo with their due permission. This was a homeless person with a positive case by means of a community active tested And we work in an intersectorial, cross-sectorial way to define the social determinants that are present in this case, and we provided the coordination and support for the fulfillment of the treatments because this person had specific circumstances, so we needed a multi-sectorial work to achieve a success rate. So we also manage, apart from the continuous monitoring, the further insertion within the community once again and the cure of TB. So we keep working in this type of population at risk, which are the lessons learned in the case of Costa Rica in terms of TB care since the detection, follow-up, and finish or cure. We have a high success rate because our teams are very trained in the proper condition with the proper knowledge to address the population at risk once a positive case is detected. Even in some cases which are derived to the third level of care, they are delivered the instruction to follow with the treatment. This means that even if this person needs a more specialized treatment, they don't need to mobilize to the healthcare centers, but our teams from the IBAIs are in charge of making the follow-up and also with the community manager that we are implementing at all PHC. We also studied all contacts in case of a positive case and all the visits to contacts that allowed us to interrupt the change of transmission. Also, the role of the primary care technician when we talk about vaccination, dengue, TB, they are essential because they have an essential role at a national level because they have developed skills that one way or another are basic to address all these areas. We even have specific team members for the indigenous populations with their specific conditions. The treatments, it's always supervised by PHC members, which also contributed to the success rate. Of course, there are always challenges because we are seeing a diminish in the rate of cases, especially within the indigenous rate, and the change that we are seeing in all countries. And we need to be really aware because we are seeing an increase in the drug use in all our countries, and this is also a risk factor. We also need to be careful with migration. For our country, this is a big challenge to address. And the adaptation to new technologies into the national legislation, because this can be complicated at the time of including them or innovative treatments, because this is very much needed in our country. We have some other photos of the work of our teams. So in order to wrap this, there are new types of focus of addressing through the national plan. Here we have the milestones. This began in 2023 based on previous plans, and we are trying to reinforce this to reach those populations at risk with more positive cases. So we need a timely diagnosis, the sensitivity test, the detection of contacts. But this is something that we have been doing, so we are not trying to strengthen in order to reduce or to be able to handle the situation when the number of positive cases increased through public policies. We need to establish communication and commitment policies with government and private stakeholders. We need people with drug use problems. We have social problems. We have people that are already diagnosed. We need to get involved also municipalities to work together with us to face this challenge of TB. And the milestone 3, which is the investigation, education, and communication. We are already working on this for an integral focus by means of a common agenda. Thank you very much for your time. Thank you. Thank you very much, Dr. Fernandez, for your presentation. We know that Costa Rica has a solid PHC to respond to TB. So with this, we finish for this was. I would like to apologize with Dr. Gallo and other panelists because we have been discussing these experiences of the countries and we are short of time. So we would like to talk about a very important role in the strategies to respond to TB, because it's not only enough with the healthcare sector, and we would like to invite the work of policymakers in order to make sure the agenda and the financing is guaranteed. So here we have Dr. Luis Gallo, which works for the TB Parliamentary Front of the Americas. So from your perspective, which are the strategic priorities of the Parliamentary Front to accelerate TB elimination? Thank you. Thank you very much, Pedro. First of all, thank you very much, Pajo. I'm from Uruguay. I would like to say hi to the more than 700 people that are following this meeting, and thank you very much for renewing your commitment to eliminate TB. Within the frame of this TB Day, we are here not only to raise awareness, but only to renew the political commitment to fight TB in our region. As co-president of the Parliamentary Front of TB of the Americas, I need to be very clear. TB is still a challenge that pushes healthcare public systems and the equity of health in the Americas. While the world has achieved to gradually reduce TB, our region has increased this rate. So this needs to be taken into consideration. In the last 10 years, the incidence of TB has increased 13%, while death rate had increased 16% in the last decade. These challenges differ strongly with the strategic goals to eliminate TB and show how the region has deviated from the road. Progress is possible, but it requires urgency, coordination, and political willingness in a continuous manner. We need to close the gap between the diagnosis, which is essential. One of the most urgent challenges is that countries are not detecting TB fast enough. It's not enough to end TB if we don't know what TB is. This is not a technological problem, but it is also a political problem, where resources are allocated and which systems are being prioritized. From our parliament, we can influence on the framework to prioritize the investment in diagnosis at PHC and not to concentrating this in hospitals or in central labs. We can also demand the executive power for national strategies to guarantee that the diagnosis is directly linked to the beginning of the treatment to avoid fragmented processes. Another priority is to recover the control of this epidemic. We cannot still wait people to get into the system, which is a strategy that this is not an efficient strategy. We need to demand ministries and TB programs to drive strategies for an active search for innovation, for technology, to widen an early detection of TB, such as molecular tests, so that they can be used in the close point of detections to detect the TB and the resistance to drugs in a faster manner. As policymakers, we need to use hearings, the parliament, to add TB in our development agendas, in our households and prisons and migration programs. From the parliamentary sphere, we need to use our voices to view and the need to strengthen the programs for the care of people. We know that the most affected people from TB are the most vulnerable populations, those were people with HIV, indigenous population, children, migrants, people in prisons. No treatment is useful if the person cannot be supported in their everyday life. So this is a fault of the public policies. Another thing that must be considered is innovation and new vaccines. Another area is the development of new vaccines against TB. Incredibly, the vaccine that we use is BCG, which is 100 years old and mainly protects young children, but it does not prevent the TB in teenagers and adults where most of the cases are being transmitted. Today, after decades of transmission, new vaccines have arrived to the end phase in clinical trials, and the first global results could be known within 2027 and 2028. These studies show that an efficient vaccine between 50 and 60% may prevent millions of cases of deaths within the next few decades, apart from generating great benefits for healthcare systems. To be prepared for the new vaccines is not only a healthcare problem, it's a strategic investment to protect future generations and to accelerate the end of TB. To finish, TB, it's not only a disease, it's also a reflection of social inequality that persists in our society. To move towards the end of TB also means to advance towards more fair and just, with more equitable society, with a right to healthcare. On March 24, I urge this organization and this commitment as finishing TB. It's not only a healthcare goal, but it is also an ethical responsibility and a commitment to human dignity. Thank you.
Doctor Galo, de verdad, muchísimas gracias por sus palabras.
Thank you, Dr. Gallo, for your
por
words
compartirnos las prioridades
and
del
for
Frente
sharing the
Parlamentario. Sabemos que ese
priorities of the
trabajo conjunto con
parliamentary
los
front. We know this is a
es muy
joint
clave
effort
para lograr esa
with
respuesta
parliamentaries,
sostenible, expandir el
is
financiamiento, mejorar todo el marco
key
normativo que
to
mencionaba,
expand
ese trabajo
financing and
coordinado
the
con todos los
regulatory
actores
framework, the
y
coordinated
sectores. También
work
felicitar por el
with all the
trabajo del
lawmakers
Frente
and the
Parlamentario para
sectors.
seguir
So
avanzando. Y también nos gustaría ahora
congratulations
escuchar la
on the
perspectiva
work of the
desde la
parliamentary
sociedad civil.
front.
Sabemos,
And
y hemos
from the
repetido
civil
a lo largo del webinar,
society,
el rol
we have
fundamental que tienen
stated
en
time
la
and time
respuesta. Son
again the
claves las
importance of
comunidades
the
para llegar a las
response.
personas,
This is key to reach people, to reduce barriers to access, and to ensure that this is a response focused on center on the person. We have Leonid Leca from Partners in Health from Peru. How do you see the current response of tuberculosis, and what do you consider key to have a higher impact on people and communities? Good morning, everyone. Thank you, Pajo and Dr. Avedilo. Before beginning, I would like to send my greetings to the activists and the friends on the region in the celebration of the World Tuberculosis Day. Thanks everyone for their efforts day in and day out to reach this dream of eliminating tuberculosis in our region. Next slide, please. I want you to start with this slide because eliminating tuberculosis requires the commitment and participation of everyone here. This might be a short list, especially because it is clear that we need further financing, political commitment to face this disease. There is technology available, but we need to see how this is included in the countries. Those of us who work in TB, we know that facing this disease requires an aggressive stance focused on these three pillars: to seek, to treat, and prevent, to actively seek the cases and treating them with the best available medication, but also preventing people from becoming sick, for the infected people, so that they do not disseminate, spread this disease. So in this sense, there are 5 major groups of activities within civil society where they have been involved. There are many colleagues from the civil society here who are engaged. These 5 groups are the following. The first one is awareness and community education, but with a multisectoral focus. Besides supporting the healthcare sector, we need to work with universities and schools to continue reporting that TB is not a disease of the past, to debunk all the myths of the treatment, that tuberculosis, it only affects the poor, and many myths that we know that still remain, despite the fact that this is an old disease. Advocacy of rights and access to services. This is one of the strong points of the civil society, so policies are implemented because we know that there is bureaucracy and difficulties, and also to demand treatment and diagnosis to be free, and to protect the people from marginalization and discrimination. Thirdly, support to the patient. There are many mechanisms where civil society is engaged to make diagnosis available, for instance, treatment. This comprehensive approach is not just about treatment, but also to ensure that people receive emotional support. There are examples in some countries with advice or access to programs for economic support and social protection programs. Surveillance and monitoring. We need to help the public sector and the TB programs so that they can actually reach those who are in need. And in the examples of the last decades, we have the Social Observatory of Tuberculosis in many countries and at the regional level who are continuously working to support governments for the patients to have access to these technologies. The networks of former patients that are present in many countries trying to support this process that are very important. And the last but not least is research and collaboration. We have seen that technologies continues to advance. WHO is updating their guidelines, so we need to see how we can bring about this technology to countries to test them out. The academia here has a major role, the investigation organizations that have been encouraging better diagnosis tools. Dr. Alarcon mentioned the mini-doc strategy, that is a new diagnosis method but it can be validated in the local regulatory framework so that people can have access to it. There are better treatments. Dr. Gallo talked about vaccines, and we need to consider when the vaccine is present, it should be quickly entered into the country. Those of us who work in public health, when there's a new method or a new diagnosis, there are many years that go by so before this becomes a public policy. We need to close this gap, and civil society needs to be involved to promote better mechanisms and strategies that we need in the countries. And then to end, these are just an example how civil society is involved in the active search strategies and activities. In Peru, the community healthcare workers are part of the campaigns in supporting patients to have access to healthcare services and continue treatment. For instance, in this topic, something that is being discussed is that there is a high percentage of cases of TB without any symptoms. So it's very difficult for a person who doesn't have any symptoms but is diagnosed to receive treatment. So we need to work on this, and we need further information and education, and of course, the engagement of civil society. Thank you, Dr. Pedro, for the opportunity. I tried to summarize the civil
Excelente, Leonor.
society
Muchísimas gracias, de verdad,
involvement in these
por tus
5 minutes.
palabras también
Thank
muy
you, Dr.
inspiradoras, y
Leka,
gracias por
for
resumir
your
en tan poco tiempo las
words.
diferentes
And thank
áreas
you for
o
summarizing the
diferentes
different
aspectos en los que la
areas and the
sociedad civil y
different
las comunidades
aspects
son
where
esenciales
civil
para que de verdad
society and the
tengamos
different communities are
esa
essential
respuesta
so
plena,
that
¿no?
we
Esencial
can have the
para avanzar
full
hacia
response and
la
essential
eliminación. La
response
participación
towards the elimination
significativa de
of
la sociedad
TB.
civil y la
The
colaboración multisectorial,
significant
quiero recordar que
participation of
también son
TB and the
pilares estratégicos
multisectoral
básicos
approach
de
are
todo el
key
enfoque de atención
pillars
primaria
and
en
strategies
salud,
for
¿no?
the primary health
Refiriéndose a
care,
los servicios de
not
salud o
just
las
in terms of
intervenciones
healthcare
biomédicas, sino
services
cómo se
or
puede tener
biomedical
una
interventions,
respuesta
but
muy
also
integrada
as
y
to how we can
completa
have
en
a
el nivel de
comprehensive and
territorio.
full
Agradecerle,
response at the
doctor
territory
Galo,
level.
doctor Leca,
So thank
por
you,
sus
Dr.
intervenciones
Gallo. Thank you,
y
Dr.
ya,
Leka, for your
colegas,
words.
estimados,
And then,
llegamos con esto al
my
fin
dear
del
colleagues,
evento.
we
De
have
verdad
reached
agradecer a
the
todos los
end of this
participantes
event.
que nos han acompañado
Thanks
hoy.
to all the
Hemos
participants
tenido
that were
excelente
present here.
participación,
We've
tuvimos más de
had
800
quite
personas,
a huge
todavía
turnout,
pasados
over
bastante de tiempo, nuestras
800
disculpas, pero siguen más de
people.
750
We went over
personas
time, but we
conectadas.
still have over
Recordarles que la
750 people
grabación del
here.
evento y los otros
The
materiales de la
recording of
memorial
the
están
event
disponibles en la página
will
web y
be
en las redes
available in
sociales
the web
de la
page and
OPS.
in the social
Y bueno,
media
solo
of
resumir que
PAHO.
creo que ha quedado muy
And just
claro
to summarize, I believe
a lo
it's
largo de la
been
sesión
very clear
que la
along the
tuberculosis sigue
session
siendo un
that
desafío muy
TB is
importante de salud
still an
pública,
important
que estamos
challenge
viendo
for
algunas
public health.
señales alentadoras
We
de
have
que las
seen some
respuestas
encouraging
van funcionando con las
signs that
nuevas
response
estrategias que
work
tenemos
and that
nos
new
permiten avanzar,
strategies
pero
enable
todavía
us to
tenemos
move
brechas muy
forward and move
importantes,
ahead,
personas que
but
no
there
estamos
are still gaps
que no estamos
remaining for
diagnosticando, que no estamos
undiagnosed
llegando
people,
a tiempo y que están
people who
produciendo
are not
mucho
reaching on a
sufrimiento,
timely
muerte
manner
y
and
costes
who are
también muy
suffering, who
importantes.
are
Pero el
dying.
mensaje es muy claro.
And the message is very
Sabemos ya
clear.
desde el principio sabemos qué
We
hacer,
know
contamos con esas
what to
herramientas
do. We
para
have
lograrlo,
the
ya lo hemos
tools to accomplish
repasado, las
this. We
distintas
have
innovaciones
seen all of
tecnológicas
this,
que tenemos, pero
the
también ese
different
abordaje
technological
neuromédico
innovations, but also
psicosocial muy
the
importante y sabemos
psychosocial
también dónde
approach, which is
hacerlo, ¿no?
very
Tenemos
important. We
poblaciones
know where to
prioritarias
apply
que
it.
están
There are
muy bien
priority
identificadas en los
populations that
países,
have
que
been
tenemos
properly
que fortalecer,
identified in the
enfocar más
countries
los
that need to be
esfuerzos en ellas.
strengthened
Y bueno, hoy
in
hemos
terms of
visto ejemplos
efforts.
claros
And we have
de
seen clear
experiencias que
examples
muestran que es
of
posible
experiences
avanzar.
that
Sabemos que hay
show that
muchas
it is
más y esperamos
possible
poder seguir
to
compartiéndolas
advance.
con ustedes,
We
pero
know that
creo
there are
que
many more, and we would like
lo
to
que queda
share them
claro es
with
que
you
para que
at some other
tengamos
time.
impacto
But
necesitamos
in
ese
order to
elemento
have
central, ¿no? Que es
impact,
fortalecer la
we
atención
need to have
primaria de
this
salud, la
key element,
integración de la
strengthening
respuesta a la
primary
TB
health
en la
care,
APS, porque desde la APS es
integrating
donde podemos
TB into primary health care, to articulate networks, services with the communities, to be able to detect and diagnose in a timely manner and accelerate this space towards elimination. We know elimination is possible, but it entails the joint effort of all the actors, the government, the public sector, private sector, and the civil society. So thanks to all the presentations, the speakers, and thanks to the technical, bajo technical teams of communication and the interpreters. So we hope that this exchange can promote the joint work, not just today, but also along the year, to accelerate response and to move towards the elimination of TB in the Americas. This year, we will hold a major event, the Union Conference, the most important conference of TB that will be held in Rio, in Brazil, in November, which will be a huge opportunity to continue this exchange and to show the world the major advancements in the region. So thank you once again and have a wonderful day. Thank you very much.